Good. Okay, it's absolutely fantastic to see everybody here. So my name's Aziz Sheikh. I have the privilege of being the director of the Usher Institute, and a really very warm welcome to what I hope is going to be a fantastic afternoon. So a very warm welcome to everybody in the room. It's been a long time since we've been together face to face, so delighted to bump into colleagues, catch up, meet new colleagues. Absolutely wonderful. Also a very warm welcome to everybody joining online. We know for this event we've got colleagues from across in our Usher Institute, College of Medicine, Veterinary Medicine, across the university, across Scotland, colleagues joining internationally. So a very warm welcome to everybody. We are, as you can see, in this absolutely wonderful venue. This hall was given as a gift by William McEwen, a Scottish politician, to the university for ceremonial purposes, but also to the city of Edinburgh. And it has been recently refurbished, and I think it's been an absolutely fantastic job. For those of you in the room, do look up at the dome and the fantastic murals that there are there. So a wonderful venue. The Usher Institute has been going for a long time. It's 120 years old. Edinburgh gave the world academic public health and academic primary care, and it was through the fusion of those two that the Usher Institute, in its contemporary form, was born. But since then, we've really broadened, and so it now is the main applied translational axis for the college and for the university. And so we really are very privileged to enjoy fantastic interfaces with governments across the UK, but also internationally, intergovernmental bodies, NHS leadership, and really being at the coalface there on that front. Now, we've been hosting this Usher lecture, this Usher annual lecture for the last 7 years. So we kicked off with Johnny Anides and then David Blumenthal. Then we've had Victor Zhao, Chris Whitty, and then we've had a couple where we've been online with Jeannie Shoveler and most recently Sir Martin Landry. So absolutely fantastic scholars who've really sort of graced us with their views on very important subjects, and I mean, I think we're incredibly privileged to have a wonderful Usher annual lecturer today in the form of Fiona Godlee. So Fiona and Zach in particular, a very warm welcome to the two of you. Thank you for being here. So when I approached Fiona about this, I asked whether she would be interested in doing something on the future of medical publishing. And the reason was that, I think for those of us who are kind of live the academic life, you get incredibly used to rejections. I think it was probably the area that you developed the most expertise in. And I remember that my kind of most memorable rejection, Fiona, was I sent a paper to the BMJ, and before I'd had a chance to even let the co-authors know that the paper had gone off, it was 15 minutes to the rejection. And I thought maybe, the future of science, maybe you could get an answer actually much quicker. Maybe just enter your name and you get rejected straight away. But anyway, Fiona decided to speak about something much more important. I'll have that conversation with Fiona later personally about how I might be able to do better, but something much, much more important. So really looking forward to this. Obviously, for those of you in the room, there's also, you've had the chance to see some of the marketplace, the posters on display. The posters are also available for colleagues online. What you have to do is available online. For those in the room, you can use your QR code on your name badges. And so please do that, because that's going to be the vehicle by which we entertain questions. And so please, do engage with this, put your questions, make clear who you want to answer the question, and Linda and David will field those questions. Maybe just finally from me, what we try and do every year is have one of our centres host this annual lecture, and this year it's the turn of our wonderful Centre for Population Health Sciences. So what you'll have the opportunity to do is get a bit of a taster of the fantastic work that's going on across the centre. To take it from here, it's a great privilege to introduce Professor Linda Bald. Linda co-leads our Centre for Population Health Sciences with David Weller, a fantastic academic, policy expert in her own right. And Linda, thanks so very much. Over to you. Thank you.
Thank you very much, Aziz. And isn't it absolutely wonderful to be together in this astonishing venue that we're very privileged to have access to. So thank you to all of you who've come in person to join us today. And as Aziz was saying, thank you to everybody who's joining online. As Aziz was explaining, every time we've run this Usher annual lecture, we've had different centres hosted. And I'm very fortunate to co-direct the Centre for Population Health Sciences with David, who I'll introduce in a moment. And CPHS really goes right back to the history of the beginning of Usher, as Aziz mentioned, bringing together the oldest chair in public health that I hold at the moment, and also the oldest chair in general practice that David holds. So bringing that together, and now of course today we have a very vibrant Centre for Population Health Sciences with many academics, with many policy and practice links covering a wide range of topics. And so what we wanted to do today was to really give you an overview of some of the great strengths of our centre. So you'll hear from academics who are engaged in research and also our colleagues who are leading the teaching. And CPHS does a lot of the teaching that Usher contributes to the College of Medicine and Veterinary Medicine, including our undergraduate and postgraduate programs. So David is going to start by giving you an overview of CPHS and the history, and then what we'll have is a series of speakers. And when you're listening to the speakers, and they're very short fire presentations, I had to make not exactly a joke about the umbrella handle appearing if they went over their 2 minutes, but I'm sure none of them will. 2 to 3 minutes. Please, as you're listening to our colleagues, if you have a question, do follow the instructions there and pop it in the Slido. And David and I have got our laptops here so we can see the questions as we come through. But anyway, delighted to introduce David, who's been a real privilege to work with over the last few years. He is a co-head of the CPHS, but also the James Mackenzie Professor of General Practice, and he'll provide a history of our centre. David.
Thanks very much, Linda. If I could have the first slide. Yes, the history of CPHS in 2 minutes. That's a bit of an impossible task. But I want to just add my own welcome as co-director of the centre. It's wonderful to see so many people here from such diverse backgrounds. So I can't do a history in 2 minutes, so here's some pictures to show you, and some of these people have already been mentioned. Yes, we formed from two previous departments, public health and general practice. Andrew Duncan is a key figure in our history. He set up a public dispensary out in the community, which treated the poor and the sick. A predecessor for our own Mackenzie Medical Centre. James Mackenzie bequeathed a chair in general practice, and Richard Scott became the first professor of general practice in the world. And he was succeeded by John Howie, who was really one of the pioneers of academic general practice. We have a very strong equality and diversity agenda, which isn't reflected in this photo, perhaps, but we've done our best. In no particular order, John Usher, he's one of the reasons that we're here. He bequeathed the chair and began that Institute of Public Health, which later moved to Edinburgh. Henry Littlejohn, he was a great forensic scientist and public health official, the first medical officer of health, great supporter of public health here. Sydney Smith, our dean in the 30s and 40s, he's also a great supporter. Frank Crew, he was a pioneering geneticist and helped set up the general practice teaching unit. Mike Garraway, again a leading figure. He did a lot of work on stroke rehabilitation and was instrumental in bringing the department centrally. And I just thought I'd mention as one exemplar Helen Zealy, who was one of our great links to public health in the NHS. So These are just some of our research themes which you're about to hear about. We're a forward-looking centre. We're multidisciplinary. We'd like to think that we have high-impact research. We have an annual research expenditure between 6 and 8 million. We've got a very flourishing undergraduate and postgraduate teaching program, a great diversity of themes. So we hope you enjoy the following potpourri of topics. They've been selected just to give you a taste of what we do in CPHS. So again, welcome. Thanks very much for coming.
I'm just going to invite our speakers from CPHS to come and join us at the table, which will facilitate, I think, the rapid movement between them. And our first speaker, really delighted, we were meeting this morning to talk with our colleagues from Diabetes UK who've also joined us. We're really pleased that they're here. So I'm very happy to introduce Professor Sarah Wild, who's Professor of Epidemiology, who's going to start off. Thanks.
Thank you. Thanks very much, Linda, and for giving me the opportunity to speak to you today. It's 3 minutes isn't long, is it? So I'm looking out for the trapdoor opening. So if you see me doing this, I've disappeared. So may I have the first slide, please? So my name's Sarah Wild. I'm Professor of Epidemiology. Last month, I'll have been in Edinburgh for 20 years. It's really nice to see some people here who I know from Cambridge more than 20 years ago. So look forward to catching up with them. What I'm going to talk about today, very briefly, is diabetes and COVID-19 in Scotland. And one of the key things that I'm going to start with is pointing out that the risk factors for diabetes and for COVID-19 are really very similar. So I've given the list there. I won't work through them. They'll be all familiar to you from the news. And this illustrates the situation that's sometimes called a syndemic of communicable and non-communicable disease, underlined by the causes for health inequalities, which, to summarise, are the unfortunate combination of global capitalism and human nature, which are, of course, extremely difficult to change. So having established that the risk factors are similar, what about the combination? What happens with people with diabetes who get COVID? So in Scotland, we're incredibly fortunate to have a population-based register of people with diabetes that covers, we think, nearly 99% of people with a diagnosis of diabetes in Scotland. And we can use this register for all matter of epidemiological studies, but clearly in the recent past it's been particularly helpful to study the association between diabetes and COVID. So this first slide describes colleagues' work on the outcomes of COVID in people with diabetes compared to people without diabetes. And the bottom line is it's bad news having diabetes, it's bad news having COVID, but having diabetes and COVID together is particularly bad news, is the brief summary. The good news, however, though, is that the risk, particularly in young people with diabetes, is fortunately very low, the absolute risk. And so in terms of whether extra shielding was required for young people, this evidence suggested that although they were at higher risk, their absolute risk was not particularly high. So there's a brief illustration of some of the work. There's also been a lot of interest about whether having COVID increases the risk of getting diabetes. And again, this summarises colleagues' work that show a suggestion that there might be an increase. I'm sorry, the time's run out. There is the slide on the right that shows some increase in type 1 incidence, the type of diabetes that occurs amongst children. And I'll stop there before the trapdoor opens.
Brilliant. So I'm sure that left lots of questions in people's minds given the short time, so do pop them in the Slido. Really delighted now to introduce Dr. Christine Campbell, who's a reader in the Usher Institute and has done a lot of work on cancer and related issues. Christine.
Thank you, Linda, and good afternoon, everybody. There are approximately 33,000 new cancer diagnoses in Scotland annually. Globally, that figure is closer to 17 million. The work of the CPHS, Cancer and Primary Care Group, traverses the cancer control continuum, from screening through symptomatic presentation to survivorship care, both in Scotland and internationally. Today's presentation is going to highlight work on screening. Our research addresses issues of access, understanding and addressing barriers to participation, and with an emphasis on disadvantaged and often excluded populations. The UK's National Screening Committee has just very recently recommended the introduction of targeted lung cancer screening. The LungScot project is an ongoing pilot intervention to test the feasibility and acceptability of low-dose CT screening in Scotland. Working closely with NHS colleagues, the research is examining how best to identify high-risk individuals, smokers, using primary care data, and how to deliver a programme of screening that's accessible across socio-economic and geographical boundaries. In contrast, although cervical screening is well established in Scotland, but participation varies by a number of factors, including ethnicity. The SCREEN study has been examining this variation through data linkage of cervical screening data with the 2011 census, in-depth interviews with women of diverse ethnic groups in Scotland, and examining the international literature on effective interventions. And this work is now informing a future intervention in Scotland. Globally, turning to global issues, Malawi has the highest cancer mortality for cervical cancer. We've been working alongside the Malawi Ministry of Health and clinical and academic colleagues to implement a screen and treat programme, particularly focusing on disadvantaged rural areas where there's little coverage. Within these communities themselves, there are vulnerable women, some at a high risk of developing cervical cancer, such as women living with HIV, and targeted initiatives have been developed to reach these groups. Dunladi Adamu has been examining practical challenges and opportunities for introducing cervical screening in Gombe State, Nigeria. His work has focused on the potential roles of community health workers and civil society, as well as the knowledge, attitudes and beliefs of women themselves. Cultural norms and practices have emerged as important factors, and Dunladi is now working on implementation strategies. Across all these settings, there are important commonalities. The screening invitee has to be at the centre of the planned services and hence associated research. And in every setting, it's vital to work with local communities to build trust and ensure all voices are heard. Thank you.
And now Bruce Guthrie, who's here.
So thank you. I should try and be quick. So I was going to just talk about clinical predictions. So what does clinical prediction matter? It matters because increasingly guidelines tell you to treat on the basis of risk. And if you want to target expensive interventions, you want to do them in people at the highest risk, not in people at low risk. And there's issues with how all these things work in older people. So the first thing, if you know anything about prediction, people often talk about does a prediction model discriminate? And that's based on things called C-statistics. The problem is, if you only look at the C-statistic, you can be really easily misled. So this is evaluating acute fracture, so it predicts your risk of osteoporotic fracture. It's used to guide treatment decisions. If you look and this is externally validating in a different data set, if you look in all patients, discrimination is good. So C-statistic, 1 is perfect, 0.5 is random, 0.8, it's about as good as it gets. But that's largely driven by age. And so you have a model which predicts over 30 to 99. It's a bit like Sarah was showing with COVID. Actually, diabetes, gender, none of that matters for COVID mortality compared to age. Age dominates everything. And when you look at the C-statistic in different age groups, actually in oldest people, it's not much better than chance. That's completely unacceptable discrimination, but we still use this model. So be suspicious of models which include large numbers of age. Discrimination is unlikely to be real. The second issue in older people is that almost all models ignore competing risks of mortality. So they predict your risk of something happening if you don't die of something else. And that's okay in young people because they don't die of anything else. So if you look on the left, the lower line is the rate of major osteoporotic fracture, and it goes up with age, and it goes up a lot with age. And the top line is non-fracture mortality, which goes up way faster. And so competing mortality, predicting your risk of something happening if you're not going to die of something else, doesn't make sense if you're pretty likely to die of something else. You seriously overpredict the risk of the event and you overtreat. On this side, so this is calibration. If you're interested in prediction, you need to look at calibration. So this is the whole population divided into groups of 10 in increasing tenths of predicted risk. So that's the black line, that's the predicted risk. The red line is the actual fracture rate once you account for competing mortality. And as you'll see, it goes down. So the fracture model is saying these people can have lots of fractures. Actually, they have fewer fractures. Why? Because they die. People at high risk of fracture are also at high risk of death. This is in 85 to 99-year-olds. It works better in younger people. So, you know, what should we do about clinical predictions? So this is work in the Advanced Care Research Centre. We're very interested in prediction. Be suspicious of discrimination. Age dominates everything. If you're predicting over a wide age range, discrimination is not meaningful, or may not be meaningful. You've got to account for competing mortality. Predicting people's risk of something happens if they don't die of something else when they're quite likely to die of something else is not sensible. It leads to overtreatment. There's issues about older people. So, you know, these are all predicting osteoporotic fracture risk. Actually, in older people, it's probably falls risk that matters. If you fall over, you break your wrist. It's not osteoporosis, it's the wrong risk factors. And actually, you really want to predict for multiple outcomes. Not, you know, one thing at a time isn't enough. Older people have got lots of things wrong with them. Thank you.
Thank you, and I'll hand over now to Professor Hilary Pick.
Thank you. I like a challenge. I imagine my slides are going to just appear, are they? Do I have to do that? I like a challenge, so I thought I'd sum up in 3 minutes of at least a decade's work around helping people to live with asthma. This represents work from a number of major projects, but also UK-wide, increasingly perhaps global, and much of it under the auspices of the Asthma UK Centre for Applied Research and increasingly the Respire unit. So helping people to live with their asthma, the jargon is self-management, and this is a reasonable definition that emphasises the breadth of that. It's not just clinical, it's around the role and the emotional management of living with a long-term condition. It's around living with asthma. If you look at it from the patient's perspective, they spend a matter of, this is the default position, they spend a matter of minutes with a clinician, perhaps each year. All the rest of the minutes of the year, they are taking the decisions as to what treatment they take, when they call for help, etc. So our role, and I'm talking here as a healthcare professional, our role is to support them to do it better. And this has been an interest of mine for many, many years, and I've been working with colleagues around the UK. This is some work we did with Queen Mary's in London. We looked at an overview of the literature around supported self-management and pulled out from not just asthma, this was a number of long-term conditions, the type of support that healthcare systems could offer and produce a taxonomy. And what we realised was that it depends on the condition. You know, if you've got an asymptomatic condition, you need a monitor to, like a sphygmomanometer to monitor it. And this is something we did with the telescope work here, rolling out home monitoring for blood pressure. If you've got a disabling condition, you might be more focused on the equipment that you need and the social services that you need. Asthma's defining feature is it's a variable. Everybody with asthma needs to know what to do if your asthma gets worse. And the classic way of doing this is to provide, following on from a conversation about self-management, but to summarise it in an action plan. And what we know is it works. Our systematic reviewing has showed us all you need to know about that slide is that all the lines, all the diamonds are on the left-hand side, which means it's an effective way of reducing admissions, A&E attendances and GP attendances. We also looked at what patients felt about this. We heard that they learnt how to manage their asthma experientially over time, but they could be supported by their healthcare professionals. We hear that the professionals need to be skilled to do this, and we looked at many ways in which teams could be supported. We also looked at the barriers that come from the organisational context, where GPs see people acutely, nurses provide the action plans, and they don't necessarily work together. We hear that templates are really important because they help to structure reviews, but if self-management's on the second page or at the bottom, you may never get to it, so we've restructured those. We've also heard how important it is, and this is a PhD student from the ASME UK Centre who looked at what happens when you look at, say, Bangladeshi or Pakistani people. They need their action plans targeted towards them. And we've continued that more globally with some colleagues from Malaysia in the Respire unit, where they've looked at using pictorial action plans to overcome the problems of limited health literacy. What we're doing now is trying to implement supported self-management in primary care. And so taking some of these themes that we've developed, we've got a quite complex implementation strategy that looks at what patients, professionals and the organisation needs and facilitating that. This is how we designed it. COVID hit, and this is how it now looks. But the same thing, but we're delivering it remotely. We looked at what the patients needed to know, could we fill in action plans remotely, and we are now recruiting practices, nearly there, recruiting practices for a trial. PhD students supporting our process evaluation and understanding aspects of what we're doing. Oh, and finally, we are also looking to the future where digital health is going to be obviously supporting that. This is for the future in smart cities and smart homes, but maybe this is the way it's going to go. So just to sum it up then, we need to be thinking about partnerships with our patients, with our colleagues, personalising it to the patient's needs and to the context. And if we don't implement it, we won't achieve the impact that we could. Thank you.
Thank you, Hilary. And we have a couple more still research examples here. So Tim Walsh, who's Professor of Anaesthesia, Critical Care and Pain Medicine and lead of Edinburgh's Critical Care Research Group. Tim.
Thank you. I'd just like to spend the few minutes telling you about a grouping rather than specific research, which we created about 4.5 to 5 years ago, pre-pandemic. The aim is, if it moves forward. I'm not moving. The aim is to essentially bring together acute care researchers from across the university and the NHS to look at new solutions to develop therapies and ways of managing patients with critical care. Oh, I've moved. So this is our website. You may ask, why did we bring this grouping together? And it is a virtual grouping. It isn't a centre. It doesn't even have any funded infrastructure. And it's co-chaired by myself as Chair of Critical Care and Honorary Professor of Emergency Medicine, Alistair Gray, who's an NHS-based consultant. And our rationale was several-fold. One was acute care is clearly very important to the modern NHS, but it's not traditionally recognised as an entity by many universities, and we wanted to raise that profile within the university. The second thing was that we recognise that much of this research is actually led by NHS clinicians, many of whom told us they struggled to know who to contact within the university to progress their ideas and their research, and this was a mechanism of doing that. And thirdly, we all recognise that pressure on acute services, such as emergency medicine, is enormous, and also my specialty, critical care, is extremely expensive. So there was a logic in doing that. And finally, doing this research is very challenging because it's time critical. So some of the ethical and logistic challenges of carrying out clinical research is quite generic, and we wanted to bring in together that expertise to enable it, particularly in large clinical trials. So I highlight here that our grouping cuts across many clinical specialties here behind me, and those I list here are all represented in our grouping, and we have clinical trials running in virtually all of these areas. So our key activities and successes, really over the last 4.5 years, and partly in relation to the expansion of the Edinburgh Clinical Trials Unit, we now have about 12 or 13 NIHR or BHF or other high-profile multi-centre studies funded in this space with a mixture of university and NHS PIs or CIs. And these cover a wide range of clinical areas, some of which I've listed here. We're really expanding the opportunity offered by the DDI programme to drive data-driven research, and are very interested in outcomes and the influence of multimorbidity, and particularly bringing this to the front door of secondary care to improve the efficiency and enable things like realistic medicine decisions in time-critical environments. And our grouping in different ways made major contributions to the COVID-19 effort, largely through reorganising how we did research in the NHS. And finally, we're really expanding our innovation activities and engaging with innovation in redesigning care pathways in acute care going forward, aligning with the Scottish Government's priorities to really recover from COVID through redesign of care services. And I'll finish there. Thank you.
So we're going to move in the next two presentations to hear about the teaching which we do. And Dr. Helen Eberall, who's a lecturer here in the Usher Institute, is going to tell you a little bit about our undergraduate medical education.
So in the 2020 to 21 year, as part of an MBCHB curriculum redesign, a new social and ethical aspects of medicine strand was introduced to run throughout years 1 and 2, led overall by Jenny Harden. Within this, I led the development and delivery of a new Health in Communities unit, which runs throughout the second semester of year 1. So the unit brings together public health and social science to foster the development of a critical approach to public health. It takes students on a journey from the background and key concepts of public health and health promotion through explanations for health inequalities to structural determinants of health in the 2020s. We work through different types of public health action, from population level to community and settings approaches to primary care and individual level, considering the aims, benefits, drawbacks and challenges of each. And we cover contemporary public health topics, some of which students might not have considered as public health issues. There's an integrated 5-session community practical to facilitate applied learning and provide a real-life insight into the impact of health inequalities and the role of and challenges for different community-based professionals and services. Each group of students meet with a GP tutor, a community link worker and representatives from 2 local third sector organisations. Students learn about the locality where the GP is based, and each group has a patient vignette with a range of health and social circumstances designed to align with the specific local third sector organisations I've connected them with. And the case study forms the basis of their discussions. So far, the practical has run entirely remotely the last 2 years, but this year some elements will be in person, and there's a timetable slot this year for students to visit the locality that they're focusing on. Last year, this involved 21 GPs, 16 community link workers, and over 25 local third sector organisations. And the community-based professionals really valued the opportunity to contribute to the medical curriculum, and mention of it at local events, such as social prescribing and link worker events, mean that it's also attracted interest not only from the third sector, but also from other medical schools. With 300 or so students in the current first year, it's going to grow massively again this year. So any links anyone here has with local third sector organisations, I'd love to hear. Including this unit as a substantial proportion of the Year 1 curriculum sows the seeds in fostering the development of well-rounded future doctors by providing important foundations upon which teaching in later years can build. In the context of the current cost of living crisis, this has never been more important.
Thank you, Helen. Finally, Dr. Naina Roa-Dewar, who's going to tell you a little bit more about our MPH, and she's one of the co-directors for the online MPH. Naina.
Thanks very much, Linda. Delighted to be here. I was actually going to talk a little bit about our whole portfolio of 7 master's programs in Usher. So we have one MPH campus, which is it's just fantastic to see. We have 57 students who are back on campus after 2 years of being online, so it's wonderful to see. And then we have 500 students across the world who are studying in our 6 online master's programs. So all these 557 students, and the portfolio is a projected income of now 3.8 million. And we have a fantastic dedicated staff team as well who are supporting all these students. But what I'm going to talk about today a little bit is about how we foster connections with our alumni, because that's something we started working about in the last couple of years. Because obviously when our students come here, they already come with fantastic expertise and experience and different perspectives from all these different professions they're from and from their life experiences and these different global settings. And we don't want to lose that when they graduate. So we work with our alumni in a few different ways. We really do both teaching and learning beyond graduation now. So we have our, oh, that doesn't seem to work. We have our Uncover initiative, which I think is one of the most exciting initiatives I've ever been involved in. And it's one where groups of students and staff work on evidence reviews on COVID-19 for external stakeholders, so the WHO, the Scottish Government, really big players, and students get employability, skills and professional and personal development through this. And that has inspired our second initiative, which is much more recent, which has been funded by the Deanery, and it's the UMA network, which is the Usher Masters Alumni Network. And this is a fantastic one where it's come both from our desire to keep in touch with our alumni, but also their desire to keep learning and keep in touch with us, and actually also to influence the current students. So one of the things that differs from other alumni networks is that we have current students being involved in the alumni network. So we have online events. We've done 3 online events so far. The latest one was an imposter phenomenon, which was incredibly popular. And we wish to continue with that throughout the year. So if anyone's interested in getting involved, any students or any alumni or any staff, then please contact me. We also have our fantastic students involved in teaching after graduation. So many actually of the teaching staff are graduates from Edinburgh University as well. So they're involved as peer mentors, tutors, and even co-supervisors. And it's important to say here that we have very experienced staff, academics who are supporting and training these graduates. So again, that's something that we'd like more people to get involved in. And yeah, that's how we build our kind of thriving postgraduate alumni and current student academic community. Thank you.
Thank you very much, Nea, and all our speakers for highlighting the work within the centre. We've got a few minutes for questions. I've got questions that have been posed for all the speakers, but I'm not going to be able to run through all the questions that were asked, and they were brilliant. So we'll just start with a couple. Just a question for Christine, and I think this is a really nice, broad question, and your microphone there should be working. How can we ensure that cancer screening doesn't reinforce health inequalities?
Thank you. That's a great question and central to a lot of what we do. There are various initiatives in Scotland trying to really understand and unpick some of the barriers to participation, but critically also working with the communities and the groups themselves to address these and to think of strategies that would be acceptable. One example of that is for cervical screening, and there's a lot of work going on around the introduction, for example, of HPV self-testing, which for some groups is maybe a more acceptable approach. But I think with any intervention, any prevention intervention, there is always a danger of increasing inequalities, and it behoves us to monitor that incredibly carefully and intervene where required. Thank you.
Thank you, Christine. And Tim, really, again, a question all of us would like the answer to. How do we reduce pressure on emergency services at the moment? And is there research that will give us insights into what we can do?
Seriously expect me to try and answer that question? I think I don't have the answer to that question. One of my other hats is Director of Innovation for NHS Lothian, and I think we need to use data to reduce the time clinicians need to spend gathering information, and there's certainly potential to do that regionally with data lock and the systems that are there. So a lot of the innovation work we'd like to do is to automate dashboard creation to save clinicians time. Clearly, if we do that, that may enable decisions to be made and realistic medicine type decisions to be made in a more appropriate way and help our junior colleagues. So that is one of the approaches we'd like to take. In terms of unblocking bed flows through hospitals, I'm seeing with that hat on almost every service gradually coming forward and saying, can you help us innovate our system digitally? And I think that, to give an example, with the hip fracture pathway, we're doing a piece of work with a commercial company at the moment to try and automate the pull of data into an evidence-based guideline-driven pathway so that people don't go around with bits of paper auditing after the event, but are pushing evidence-based interventions in real time. And also from that, you can develop AI approaches to prioritize the use of scarce resources, like which patient should get physiotherapy, which patient doesn't need it, for example. So there's no simple solution, but I think that is the beginning of the journey to try and solve some of these issues.
Excellent. And quick question for both Sarah and for Hilary about COVID and messaging and also self-management. So Hilary, did the self-management of people with asthma change during the pandemic? And in what way? And Sarah, should we give evidence about diabetes risk in relation to things like COVID-19 infectious disease? Is that a good thing to do?
Right, so did self-management change? Well, it certainly did for a week or two. We know that once the lockdown was announced, in general practice, we were inundated with requests for prescriptions for inhaled steroids that people hadn't used for the last 5, 10 or whatever years. So all of a sudden, people were interested in managing and preventing their problems. We had increased requests for oral steroids, presumably in case they needed them for their action plan. So I'm sure it works for all of a few weeks. I'm not sure how long it was maintained.
Fair enough, thank you. Sarah.
And in response to the question about diabetes, I mean, I think what we found was that actually advice for people with diabetes didn't need to be any different from that for the general population. And that would go for lifestyle measures as well. In fact, I think a lot of diabetes control improved during the lockdowns. People had fewer temptations, perhaps lifestyle temptations. But as we well know, overall, people tended to gain weight during the pandemic, and that's been a bad thing for people with diabetes, as it's a bad thing for everyone. So same advice for the general population, I'd say.
Fantastic. And Bruce, there's a couple of questions for you which are all about modelling, so I'm not going to put you on the spot today, but I think the importance of using models and how can we really account for some of the, I guess, the limitations.
I'm a bit deaf post-COVID, so...
Not at all. So I guess I'll ask you the precise question that somebody asked, Bruce. Are there robust models that account for competing causes of mortality?
Yeah, so, I mean, competing risk is straightforward. I mean, it's a technical fix. It's just not thought about if you use conventional survival modelling. So Kaplan-Meier estimate doesn't account for it. It's straightforward to account for it. It's just not thought about. And it's not thought about because people are thinking about young people when they're thinking about predicting risk. But actually, the health service is when I was a medical student, most people in hospital were under 65. But now, I guess, they're almost all over 65, the vast majority. So I think it's just people don't think about older people. It's not a problem in younger people, and therefore it's just not considered. And so that reflects societal stigmatization of older people. Competing mortality is straightforward to fix. Other things are a bit more complicated.
Thank you very much. So I'm not going to go into any more detail on the questions now, but just to thank in particular Nea and also Helen just for highlighting the important contribution that teaching makes to the work of CPHS. So I hope you found that interesting. We're going to pass over now to hear more about the main event for this afternoon, which of course is our keynote lecture. And I'm particularly delighted now to introduce Professor Liz Grant, who's going to say a few words before our keynote speaker joins us. So Liz is Director of the Global Health Academy and Assistant Principal Global Health at the University of Edinburgh, and she's also Chair in Global Health and Development. So thank you very much, Liz. We'll hand over to you now, and thanks again to our CPHS speakers.
Thanks so much, Linda, and what a wonderful panel that was of just so much information. So what I'm going to do is ask everybody just to stand up for 1 second and look up at the ceiling. And Aziz has already mentioned this. Look at that ceiling. It is extraordinary. What do you see? You can sit down now, but hold the image. And the reason that this image is really important, the reason it's extraordinary that we are in this building, that we are, celebrating and also being challenged today about where climate change is taking us and why health is the fundamental climate change issue and why health workers, health people, health policy can change climate change. It's something to do with this roof, this ceiling, because what you have is a group of women carrying torches of medicine, of chemistry, of philosophy, of divinity, of fine arts, of jurisprudence. And what the ceiling is saying, and it actually says underneath there, I don't know whether you can see it, it says, wisdom is the principal thing, therefore get wisdom. And with all thy getting, get understanding, exalt her, and she'll bring thee to honour. What was happening here is that it's a message, it's a planetary health message. We need all of the different disciplines to come together to speak in the health world about what's happening in the world today. Togetherness. And that's what has been shown in this panel, and that's what Usher is trying to do. It's trying to bring this collation of people to think about population health, to think about public health, to think about primary health care, to think broadly about planetary health. Now, planetary health, it is as old as the hills, even though it's a term that is new in a sense in our conception, and the 2015 Lancet Commission really brought planetary health to the fore. But it really is what's underpinning the paradigm of the Sustainable Development Goals. It's recognising that there's a triple planetary crisis. There's a crisis around climate change, biodiversity loss, pollution, degradation. There's also a triple human health crisis going on at the minute, and you've touched on that. The human health crisis of inequity to health access, increasing health emergencies driven by the climate crisis, and also declining health and well-being metrics. We're not going to meet any of our SDGs at the minute if we don't take radical change. So what we know is, how do we come together to make a difference? And the reason I've put up this slide, which is, I appreciate you're not going to read every single piece of it, but there's something about the loops here that really matter, because what we're trying to say and do is that each of these loops feed into something else. What we have in one part, thinking about inequalities, that doesn't happen all of its own. It's driven by things. It's driven how we strengthen land and urban planning, how we work together to improve societal justice issues, how we bring together water and sanitation and investment, how we increase access. These are all connected. So what each of us are doing, and the narrative of planetary health, but the narrative now of public health, is to say we must work together. The pandemic showed that public health wasn't a discrete specialty, but it's a fundamental building block. It's this organizational approach to management that sits and underpins our society. But public health and the broader health now has a responsibility to call out, to take into action what Fiona is going to speak about, to speak to the biggest crisis that we have going forward. What we across the university and here from Usher are doing in this space, we're launching a new Planetary Health Masters, and you've already mentioned this wonderful resource on cover, which is now also investing in thinking what's the climate change and health literature that we need to respond to. I just want to draw also to your attention a couple of the fantastic pieces of work that are coming from folks who are linked to Usher, working in Usher, who are demonstrating that they, as health practitioners, as health educators, as health policy people, are bringing change in the community, in the hospital, across education. And here you've got just these two graphs at the far end here, are work that Glennon Nightingale and a group are doing, which has been funded by the Centre for Statistics at Edinburgh University, and they're developing an R package to quantify and to map tree-to-tree interaction. Trees that are being destroyed by floods and fires, but we need to know what's happening because trees are a source of life. The leaves of the trees are for the healing of the nation. So this work has got massive potential. It's emerging from here. We've also work here showing in the Planetary Health and Sustainable Healthcare Guide by Agata Dunsmore and the team, some of our students as well, drawing together a teaching around a clinical educator model and module around sustainable healthcare. And also then the work of Hilary Young and Erica Aspinall thinking about how do we green our practices. And at the far left of me as well is some of the pieces of work that we've done funded by Wellcome Trust, which really says let's think about this intersection of health and the environment and let's speak into it because health, community have a very particular role. So what I want to do now, just giving you that little taste, is to turn to introduce our keynote speaker for today, Fiona. And so many of you will recognize Fiona Godlee. You'll know her from her role, particularly her role as the Senior Executive Editor of the BMJ. And this is an advert. If you haven't looked at this week's BMJ, do, because this week's BMJ Climate Special Issue, there's so much in it that is talking about where all of us can take this conversation. It's talking about how we normalise a conversation around the climate crisis and health role in being responsive, how this becomes something that is on all of our tongues, how we talk to our children, how we talk to others, how we talk to people in supermarkets, but also how we make choices so that we can move towards a well-being economy that responds. So can I invite Dr. Godlee to come onto the stage, and I'll describe a little bit as well about your roles. It's such a pleasure to have you here. Come here. As I say, you're a medical doctor, you're an editor, writer, campaigner, visionary, because you've done so much in the past, and actually as we reflect on this idea of wisdom, you've also really brought together whole sets of wisdom. As you know, when Fiona was in the BMJ, you also were editorial director of its parent company of the BMJ, and prior to that you were the founding director of BMJ Knowledge, you're founding editorial director for medicine of Biomed Central, and you co-editor of Peer Review in Health Sciences. So you have a great sense of and a great understanding of complex knowledge sets and bringing them together. But what I also want to reference is, since you've left the BMJ, you've been passionate about this conversation on climate and health. And you've taken on board, you've been a real supporter and actually part of the foundation of the Climate and Health Alliance community, of which many of us are part of as well. And you've been supporting the Royal Colleges across Scotland to speak about this. And as part of your role as well, you're a trustee of the Eden Project and you chair the Eden's Board Affairs Committee. And if you haven't come across the Eden Project, it's something to look up. It's an extraordinary piece of work in the south of England, an extraordinary place where we're looking at what nature can tell us, what nature can do, and how, if we allow and respond to the signals and signs of living well, then things can change. I'm going to finish with one message, that in the BMJ, there's a real message around hope. Hope that we can do something, hope about the strategies that we can take forward. So thank you, Fiona. The floor is yours.
Thank you. Thank you very much. Thank you very much. Thank you so much, Liz, and for all your hospitality and for the invitation. And also, Aziz, I'm so sorry about the rejection. You're managing it very well, and I think you've recovered marvellously. It's a huge privilege and a huge pleasure to be here in this gorgeous venue and to speak to such a fantastic multidisciplinary array of public health researchers and those of you from the wider health community. And I'm delighted to know that there may be people watching online, and I hope if you are, you might email me. I've got my email at the end, and say hi. So, yes, Aziz did ask me to talk about the future of medical publishing, but I chose this topic instead, and I'll just begin by giving you a quick scoot as to why that was. It may come as no surprise, but like all of us, I've been on a journey in relation to climate change, and it has led me over the years to the view that climate change is the most important problem we face as a species, that it poses an existential threat to human health and survival, and that the choice now facing each of us is not whether to act, but how. So in 1990, soon after I joined the BMJ, I wrote a series of articles on climate and health, or the environment and health, and these were published in a book. Encouraged by the then editor Richard Smith, in 1992 I went to Rio to report on the Earth Summit, which was the precursor to COP. It really was COP 0, if you like, and that was 30 years ago. The BMJ continued to publish and comment on climate change, and then I became editor in 2005, and climate change was on a long list of issues I wanted to prioritize. I wrote about the need for our readers to tackle climate change, and with Ian Roberts about the need to reduce the carbon footprint of medical conferences. Perhaps it was the tone of what I'd written and the call for doctors themselves to take action, but the backlash was harsh and came as a surprise. Letters from readers saying, what was this to do with medicine? Saying I was naive or poorly informed to think that climate change was the result of human activity. This was 2006, 2007. These were doctors speaking. That I was taking the journal into political and controversial areas, and most troubling of all, that I was a hypocrite because of my own air travel and the fact that we published a weekly print journal with a huge carbon footprint. One group set up an interactive map aiming to track my past and future travel. We can assure you, they said, that we will not allow Dr. Godlee to display the hypocrisy of her behaviour without a response. Her editorials are nothing but ego trips of feel-good ideas and failed deeds. Well, compared with some of the social media onslaughts people have to face these days, this may be moderately mild, but it felt very personal. And I remember feeling foolish and isolated and worried that I had in some way damaged the journal and my own still young credibility within it. So it took a few months, perhaps a year, to fully recover, I think, to recover my courage. But of course I did recover, and we carried on publishing on climate change and doing other things beyond just publishing words. And I'll tell you a little more about those and what the early setback taught me. But first, I thought I would give a quick scoot through what we know about climate change and its effects on health. I'll go through this quite rapidly. It won't be telling you anything that you don't already know. Indeed, nothing I'm going to say is new. I will be interested to know, indeed, if anything you hear from me comes as a surprise. But forgive me if what I say sounds bleak. The situation is bleak. But there is hope if we act, if each of us and all of us act in whatever capacity we have available to us. And I want to also acknowledge that many of you here are already, as we've heard, deeply concerned and committed and are acting on climate change to your fullest capacity. And there's a huge amount of good work happening in Scotland in particular. In Edinburgh, you have research and teaching that is clearly world-class. And you have the Edinburgh Earth Institute, the Edinburgh Futures Institute, to name but two. And I know that Edinburgh's students are leading the charge on this issue that is so key to young people. But while you're listening, here is a question to ponder. Given the urgency of what I hope will come across in what I'm going to say, why are we not, as a society and as a profession, on an emergency footing? Where is the public health voice calling this a public health emergency? Where is the COVID-style public health campaign? So, with that preamble, here's what we know about climate change and its impact on health. The climate science is unequivocal. The world is heating up. The past 7 years have been the 7 warmest ever recorded. Climate scientists agree that if average global temperatures increase to 1.5 degrees above the pre-industrial average, there is a high likelihood the planet will tip into irreversible climate change with catastrophic consequences for life on Earth. Current global average temperatures are around 1.1 degrees centigrade above the pre-industrial average. There is uncertainty about what the tipping point may be and when we will reach it. There may indeed be an accelerating series of tipping points, but at current rates of warming, the latest estimates say we will hit 1.5 degrees centigrade in or around 2031. That's in 9 years' time. We know that the cause of this global heating is the build-up of greenhouse gases, most notably carbon dioxide, which, although not the most potent, is the most abundant and the longest dwelling in the atmosphere. We know that levels of carbon dioxide in the atmosphere are at a level never seen before, and that current global temperatures are unprecedented in the past 2,000 years. And we know, in the words of the IPCC, that this temperature rise is unequivocally due to human activity. The observed temperature rise follows the path of the simulation that includes both human and natural activity. We know that rising temperatures are just one part of a wider assault on the planet's health, with mass extinctions, environmental degradation, pollution, and loss of biodiversity destroying the intricately interwoven systems on which all life on Earth depends. So, what of the impacts on human health? Climate change is already causing injury, disease, and death around the world through heat waves, wildfires, storms, floods, droughts, famine, conflict, infectious disease, and mental ill health. We know that extreme weather events and their consequences will happen more frequently. We know that rising temperatures, changing climates, environmental degradation, and rising sea levels are shrinking the area of livable and productive land, displacing more people, adding to the numbers displaced by recent wars that are themselves fueled, as in Ukraine, by the world's addiction to oil and gas. The climate crisis is becoming a humanitarian crisis. Conservative estimates put the number of climate refugees by 2050 at more than 1 billion. The recent heat wave in the UK has given us a taste of the sort of temperatures routinely occurring in parts of the world that are already beyond the limits of survival for vulnerable groups. We are learning about the importance of the combination of heat and humidity affecting humans' ability to sweat. The wet bulb temperature is the thing we need to keep an eye on, and creating conditions in which it is too hot to work and then unsurvivable. Modelling finds that at about 2.5 degrees above pre-industrial temperatures, 1 billion people globally will be affected by conditions in which it is too hot to work, and 20 million will be at risk of death due to heat stress. We're not there yet, but that is a model suggesting where we may find ourselves. Burning fossil fuels also, of course, creates air pollution, both inside houses and outside, causing, according to WHO, 7 million premature deaths a year from asthma, lung cancer, heart disease, stroke, premature birth, and dementia. This puts a huge and growing burden on healthcare systems. And mental health is suffering. The recent WHO report published in June concurs with the February 22 report by the IPCC that rapidly increasing climate change poses a rising threat to mental health and psychosocial well-being, from emotional distress to anxiety, depression, grief, and suicidal behaviour. We humans, as has already been mentioned, are experiencing and indeed causing a syndemic a synergistic epidemic of non-communicable disease, infectious disease, and environmental degradation. These forces don't just coexist, they interact, multiplying their impacts, and they drive global and social inequalities. The impact of climate change, pollution, and environmental degradation fall heaviest on the poorest, who in global terms have contributed least to greenhouse gas emissions. These growing inequalities are themselves a threat to human health and well-being, and they require us to look at what is happening through a human rights and social justice lens. We know all this, and we also know that at the very simplest level, what needs to happen to bring carbon dioxide down. Greenhouse gas emissions must be radically reduced. Carbon dioxide stays in the atmosphere for decades. Every ton of carbon or carbon equivalent that we don't release into the atmosphere means slowing the temperature rise and staving off the climate tipping points. The reality is, however, that the emissions globally are continuing to climb. You'll see a slight dip due to COVID on this slide, but since then the inexorable rise continues. The IPCC says that global emissions must be cut by 45% by 2030 and must reach net zero by 2050. Are we on track? The UN says no. Current national climate plans will see a 14% increase in emissions by 2030. So we're going in the wrong direction, and change is urgent. In the chilling words of Ho-Sung Lee, chair of the Intergovernmental Panel on Climate Change, speaking at the launch of the latest report earlier this year, any further delay in concerted global action will miss a brief and rapidly closing window to secure a livable future for all. As a world, we've shown we can respond to immediate threats, COVID, Russia's invasion of Ukraine, but apparently not to the slower existential catastrophe of climate change. In the film Don't Look Up, which if you haven't seen, I do highly recommend, the world has 6 months to avoid being destroyed by the incoming meteorite, but incompetent, vainglorious politicians and commercial vested interests stymie those who could avert disaster. Climate change also threatens the very things that lead to good health, like clean air, safe drinking water, nutritious food, safe shelter, financial stability, social equality, access to healthcare, and social support. And here's the good news. This means that if we tackle climate change, these things become easier to provide and to achieve. There will be substantial positive benefits to health and society if we can reduce our reliance on fossil fuels. Cleaner air and cleaner water, better physical and mental well-being because of active travel, plant-based diets, and engagement in nature, rewilding, and community action. And there will be benefits for the economy. According to a study in Nature Communications in 2020, the global action required to meet the 1.5-degree target is estimated to deliver an economic benefit of hundreds of trillions of dollars. By tackling climate change, we could achieve greater global justice and social equality, restored biodiversity, fewer displaced people, perhaps even fewer wars. So, we need to get to net zero fast. Net zero is when the amount of greenhouse gas we add is no more than the amount taken away. You will have seen the bathtub analogy, I'm sure. Carbon emissions flow in through the tap, carbon capture drains out through the plug hole. The quickest way to achieve net zero is to turn off the tap. No new fossil fuels. Transition to sustainable alternatives, which are now cheaper. Improve energy efficiency, which reduces demand and is good for the cost of living. Insulate homes, also good for the cost of living. Grants were making a difference in the UK, but were stopped by the government in 2013. Investment in public and active transport infrastructure, making it easy for people to get out of or even get rid of their cars. Support sustainable diets, food systems, and agriculture. We also need to increase the amount of carbon that's captured. And there are technological solutions for this, which are very important. But Patrick Vallance, at a recent briefing of MPs, said that although these things were important and we needed to pursue them, they would not come on stream in time or at sufficient scale to make a difference in time for what we need. We need, he said, to really double down on those technologies that are already available to us, solar, wind, and tidal, etc. Then there are the nature-based solutions to protect and restore, rewild, reforest, greener cities, wetlands and rivers. Our new Environment Secretary, Theresa Coffey, surprisingly, is a fan. Nature-based solutions, she says, really are the best and most cost-effective way to tackle climate change, with multiple benefits for the environment and communities. So getting to net zero is obviously key, but we mustn't forget the need for a systems-based approach to what is a network of closely interrelated issues, represented here by the famous Kate Raworth's donut economics. In the drive to net zero, each of us has a part to play in what is going to need to be a fundamental change to the way we live. And I'm conscious here of the knowledge that you may well have, as I do, that BP, with some advice from consultants, produced the idea of a carbon footprint in order to put the onus on us as individuals and take it away from companies. But I still would like to emphasize that there are things we can all do. And Leeds University recently came up with 6 things that cost nothing and that would, if done by everyone in wealthy countries, they say, cut global carbon emissions by 25%. So these are, perhaps you can see whether you're doing any of them, eating a largely plant-based diet, buying no more than 3 new items of clothing a year, keeping electrical products for at least 7 years, flying only occasionally or not at all, getting rid of your car or keeping your current car for longer, and making one green shift, such as moving to greener energy, insulating your home, or changing pension supplier. So while those things in themselves will help if enough of us do them, I think it's also important because although they're small steps in themselves, you will find, and sociology supports this, that once you make a change, others will follow. And I myself have been inspired by action that others have taken to do as many of these things as I can. A little bit of all of them, I think. You could also sign up to the Fossil Fuel Non-Proliferation Treaty. This is one way to put necessary pressure on governments and industry to do better. And you may already be involved in other forms of activism, lobbying, open letters, campaigns, marches, and protests. For Peter Kalmus, lead author of the IPCC report, the failures of government and big business have become intolerable. Having tried all traditional means of influence available to him as a scientist, writer, and campaigner, on the 6th of April, he chained himself to the railings of JP Morgan in Los Angeles, saying he felt morally compelled to sound the alarm. JP Morgan is the world's largest investor in fossil fuels, pumping billions of dollars a year into the industry. According to the United Nations Secretary General Antonio Guterres, such investment is economic and moral madness. Guterres has said that climate scientists are sometimes depicted as dangerous radicals. Sorry, I'm not going to say that. Climate activists are sometimes depicted as dangerous radicals, but the truly dangerous radicals are the countries that are increasing the production of fossil fuels. There's a long history of successful non-violent civil disobedience, and environmental campaigns are now finding common cause with calls for global justice and against the cost of living crisis. Activism doesn't mean you have to glue yourself to buildings or get arrested. I've so far avoided those 2 things. You can join the protests, and I encourage you to do so, especially people like me. We have, at our age, less to use than the young who are currently putting their lives on the line. So, this leads me back to what I learned after that early pushback in 2006. And reflecting on this, for this talk, I have come up with 6 things. The first of these is to find some friends. I realized that I needed support, and I found that there were lots of like-minded people out there willing to give it. Again, the gender balance isn't great, for which I apologize. Initially, I pulled together a committee to advise me on what the journal should do on climate change. And these people, Richard Smith, Ian Roberts, Hugh Montgomery, Tony Costello, Robin Stott, and David Pension were key players in that advice. This committee evolved into the Climate and Health Council, and then to the UK Health Alliance on Climate Change. All the major medical royal colleges, the nurses, the Scottish colleges, the BMA, the Lancet, and the BMJ are members of this. Altogether, it represents over 800,000 UK health professionals, magnifying their voice, advocating for responses to climate change that protect and promote public health. Letters, editorials, conferences, and bike rides like this one a couple of weeks ago across London with Ride for Their Lives. You'll see that the gender and age balance has rather improved over the years. So my question for you in relation to this first lesson, to make friends, find like-minded people, is who could you link up with in your department, your research group, your locality? What conversations could you initiate? What existing initiatives could you join to add your voice? My second lesson, to make it mainstream, to make it part of your job. I tried for a while, I realized, to work on climate change as if it was my personal hobby or crusade, because it seemed like something that I couldn't do as core to my job as editor-in-chief of the BMJ, as a medical journal editor. I realize now that I had fallen foul of what David Edmondson and colleagues, writing in that theme issue that Liz mentioned, call the mistaken belief that others lack sufficient interest or capacity for climate action, which, they say, poses a formidable barrier to public mobilization and undermines our sense of collective agency. They go on to say, once the health community recognizes that cultural barriers are minimal, it is uniquely positioned to spark and shape climate action to protect human health. We needed doctors to treat tackling climate change as mainstream, as a core part of their job, and I realized that I needed to do the same. So I and my colleagues turned this into one of our campaigns. We wrote strategies and business cases and gave everyone in the team across the organization increasing permission to get involved on our time. We published lots of stuff, we held conferences, and it continues now that I've gone, as you've seen, with just last week a fabulous theme issue on climate change. So my question for you in relation to this second lesson, is climate yet a core part of your job? If not, what would it take for you to feel comfortable and confident talking about it to colleagues, patients, policymakers? Is it on the curriculums that you have responsibility for? Have you made it a priority for research funding? Could you ask all research programs to factor in a climate change strand? Climate could be in all research, how the research is done, and the impact of its findings. My third lesson, we need to put our own houses in order. We need to do this anyway, but it's very important if you're going to speak up about climate change, as I found to my distress back in 2006. We at the BMJ worked hard at this, with some success, but I still found ways to justify the print journal and airline travel. I've stopped flying completely now, but I think I couldn't have done that if I had continued in the job. All sectors need to do this, to put their houses in order, but the health sector has a particular responsibility to stop being part of the problem. Healthcare's climate footprint is 4.4% of the global total. If it were a country, it would be the 5th largest emitter in the planet. There's fantastic work underway now in the NHS, leading the world in getting to net zero. And Usher itself, I know from talking to Dave Gorman that you are pulling on all levers, investment, procurement, thought leadership, community relations, and are committed to reaching net zero by 2040, including scope 3 emissions, which is a very, very important part of your commitment. But what about flying? Flying releases 6 times the carbon equivalent of train travel. Is flying justified in your work? This report suggests not. Academic researchers are among the highest emitters, primarily as a result of emissions from flying to conferences, project meetings, and fieldwork. We find, they say, no clear obstacles to justify an exemption for the research community from the emission reduction targets applied elsewhere. What would happen to public health research if everyone stopped flying? Most doctors don't smoke, we were told in the old days. What about most doctors don't fly? My fourth lesson, we need to talk about this as a health issue and using our credibility as health professionals. That's because it is a health issue, because people care about their health and the health of their families. So health is a lens through which to engage people in the fight. because doctors and nurses have the public's trust. They are, between them, the two most trusted professions. I would like to point out where politicians are at the bottom there, just above advertising executives. And trust is needed more than ever to provide accurate information and to counter misinformation from the fossil fuel industry and investors. Health has not been prominent in the climate change debate. The Stern report, the COPs, until COP26, there was no health area at the meeting. But at COP26 in Glasgow, it did have its place. And key potential influencers were not talking about climate change. For example, the United States journals, the New England Journal and JAMA, they said it was out of scope, too political, or even still unproven. So it was an important thing that the UK Health Alliance managed to get over 200 journals, including, under its new editor, the New England Journal of Medicine, to publish this editorial. And the New England Journal had a whole page about climate change related to that. So my question to you about this fourth lesson, the need to talk about it as a health issue and use your credibility as a health professional. Are you speaking up to the top of your capacity? And who else can you persuade to speak up? My fifth lesson, spread hope, not despair, and share positive stories. We know that hope is different to optimism. Rather than simply believing things will be okay, hope is active. And there are lots of examples of positive change that we can share. The 15-minute city proposed by Paris and Bogota to reduce the need to travel by meeting people's daily needs within a short walk from their home. You heard about the Eden Project. Well, there is one in Dundee, which is the regeneration of this old gasworks and waterfront to create a beautiful place for the Dundee Guilds to showcase and also greenery within the city. NHS hospitals are becoming self-sufficient with sustainable energy. NHS has launched the first hydrogen-powered zero-emissions ambulance. Specialties are finding ways to cut the number of procedures and the environmental impact of each one. This is an example from endoscopy, which is in line with the BMJ's Too Much Medicine campaign against overdiagnosis and overtreatment, and Scotland's excellent realistic medicine programme. So my question for you is, what positive stories can you share, your own and other people's, to give those around you active hope for the future? And my final lesson, keep exploring for new ways to bring change. The BMJ had a repertoire of things that we could do, and still does. Research, journalism, opinion, letters, theme issues, convening, conferences, partnerships. Through the UK Health Alliance on Climate Change, we did many open letters, editorials and bike rides. And after the BMJ, I've been teaching and lecturing and supporting Doctors for XR and working with others to arrange a climate briefing of all MPs by the Chief Science Officer, Patrick Vallance. My question for you is, how could you extend your repertoire? How could you extend your scope? I asked at the beginning, given the urgency, why are we not now, as a society, as a profession, on an emergency footing? Where is the public health voice calling this a public health crisis? Where is the COVID-style public health campaign? It seems to me there is a large range of issues on which public health could bring its influence to bear. Stop licensing new oil and gas. Divest from fossil fuels. Divestment from fossil fuel funders. I've mentioned JP Morgan. Stop fossil fuel funders from sponsoring sport. Stop government subsidies for carbon-intensive industries. They're really substantial in the field of trillions a year to fossil fuel industry and to agriculture. Invest in renewables, green and blue spaces, infrastructure, decarbonise transport, public transport, active travel, home insulation, citizen assemblies on climate change, ministries for the future, and the final one I will dwell on slightly, the well-being economy. In the BMJ of this, the one that's just been mentioned, the special issue, there is a call to arms from Kent Boos, calling on us all to move away from growth measured by GDP to an economy that places health, social and ecological goals as the organising principles of economic activity and government policy, recognising human well-being within planetary boundaries. It adopts alternative metrics of progress that assess policy and investment against criteria concerned with holistic well-being of people and planet. Catherine Trebeck, who's the co-founder of the Wellbeing Economy Alliance, argues that the economy is a means to an end, not an end in itself. And Kate Raworth, who produced the donut economics idea, says we need economics that make us thrive, whether or not they grow. Scotland has signed up to the Wellbeing Economy Government Partnership, along with New Zealand, Canada, Finland, Iceland and Wales. We need other countries to join, and the public health community can be a key voice in pressing them to do so. I want to end with the words of Wangari Maathai, a spokesperson for the Kenya NGO Greenbelt, who I met at the Earth Summit in Rio 30 years ago, in 1992. We have come a long way, she told me. We should speak more of hope. We should not discourage each other. We must continue pushing for a more just world. Our governments are doing what they think we want, she said. If they thought that the people had decided otherwise, a different discussion would be happening. So it is down to us, what we do, how we behave, and how we make our voices heard. Let's ask ourselves how we want to be judged by today's young people and by future generations. We who knew so much and did so little, or we who not only knew but understood and made climate action our one overriding priority, who acted as nations, institutions, and individuals with urgency, integrity, and courage to build a better, fairer, healthier world. What did you do? What did we do? And what will you do? Thank you very much.
Well, thank you very much, Fiona. I think you can judge from the level of applause there just how much that expansive and knowledgeable presentation was appreciated. You touched on so many sort of critical topics. We're slightly overwhelmed with questions, so this is a difficult task for the next 20 minutes, but Linda and I are going to try and prioritise them as best we can. And we're starting off with something quite local. I mean, we are in a medical school, and we're quite enthusiastic about medical student electives in far-flung corners of the world. We've also got big programs in international education, and we promote the benefits of internationalisation and the perspectives that can give students and indeed researchers and academics. How can we, well, number one, should we abandon medical student electives in far-flung corners of the world? And secondly, how can we replace some of those valuable benefits that we get from that sort of international experience?
I think it's a really key question. I think in research terms, one of the things that I've heard Paul Garner at the London School talk about is the avoidance of safari research, where there aren't sufficient people in the area that you're researching actually built up and building capacity there. So that one thing is to make sure that we do, really genuinely have proper widespread networked groups of researchers based in the countries that we're looking at. But as for the exchange, I'm afraid that it does going to come down to much more Zooming. And Zooming is not everyone's cup of tea, and it doesn't nearly have the same impact of the warmth of face-to-face interaction. So I think we're going to have to look for the warmth of face-to-face interaction at local level, at regional level, travelling by train. And I think we're going to have to find increasingly good technological ways of exchanging ideas digitally, virtually. I don't see another prospect. Until we have an alternative to air travel, to carbon-based air travel. It's a shame, no doubt about it.
Thanks, Fiona. And next question is somebody who's offered a personal perspective. They're looking at your messages and saying, well, why should I only go and visit my family once every 8 years when, people in business, wealthy people, travel around the world indiscriminately? Where's the fairness? Where's the justice in that?
It's not fair. It's absolutely not fair. And I think the reason we have to do it is because of the example we're setting. I mentioned most doctors don't smoke. Prior to the most doctors don't smoke, we had most doctors smoke Camel, didn't we? Those adverts of showing which cigarettes doctors like most. So it took a bit of a time for doctors to pick this up, and we're taking a bit of time in this too. But I just think that we are health professionals, and we are here to protect health, and we have to begin to say that we have to lead by example. So that these other people should change too. And legislation may be the only route, or making air travel so expensive that it becomes out of the reach of most of us. It's not fair.
Okay, I'm going to try and combine two questions here. This one is about the whole policy of net zero, which isn't without its adverse effects, its risks itself. How can we sort of build the infrastructure to competently implement net zero? And coupled with that, how can we, in medical schools, how can we, are we doing enough to look at the harmful effects of global warming? So, for example, do we teach enough about dealing with elderly patients with heart failure and the effects of heat on them? So, it's a two-pronged question.
The infrastructure question is an enormous one, and obviously it would have been great if we'd started sooner. So we've got a huge challenge. There's a lot of good stuff going on. Things are changing, and I think Scotland is leading the way in a lot of those things. But it is slow to catch up, and England, I would say, is slow to build infrastructure. Zach and I have an electric car. It's quite a challenge driving around down south. The charging points are not as frequent as you need them. Whereas over in Holland, they're on every corner pretty much. So we are behind, and it's up to us, I think, to make that case to government that infrastructure is going to be incredibly important, and also to industry and commerce that they've got to step up. So to get a just transition from a carbon economy to a non-carbon economy, we're going to also have to look at mitigating the disbenefits to certain parts of society. So people working in the fossil fuel industry, working in agriculture, those people who may need to retrain into different ways of doing things. We're going to have to take that into account if we're not going to have a lot of people struggling as a result of the transition. On the medical school, I think we do need to teach all of our students more about climate change. Certainly, there was nothing when I trained, and it's only just becoming much more common. The curriculum is very packed, so rather than a separate section on climate change, I think, Bruce, your comments about over-treatment in the elderly, that already has implications for the too much medicine, the realistic medicine agenda. So one can combine realistic medicine and environmental sustainability right across the curriculum, and I think that would be the way to do it, rather than a week or even just a single lecture, as is often the case.
I'm going to read this question out verbatim, bearing in mind that there's lots of people in our institute who are involved in public health interventions and behavioural interventions. Why don't we do what we should do? Don't we need the mother of all behaviour change interventions? And if so, what is it? Is it fear or something else?
I think it's a whole combination of things, and I think of all the changes we've got to make, the change in behaviour and the change in attitudes is the most difficult. No one wants to change. Life is very comfortable for most of us. The cost of living crisis is coming in. It's very interesting to see those two issues, environmental campaigning and the cost of living, coming together, understanding that fossil fuel profits are being protected by the government, and the result is that we are not making the change we need in terms of climate, and people are going to be find very difficult times in the next years ahead. So I think that it is fear. I think it's a lot of the time it's not quite knowing how to act, That, I think, some people turn to activism because it seems to be the only way. I think people with influence, people with professional standing, people with networks, people with credibility have an enormous part to play in trying to encourage the 1/3 of the population, according to the data that I've seen, who do not consider climate change something that is any concern of theirs. So we've got a big job to do to reach that group of people and to activate and empower the people who already are concerned. I think this is the big issue: is how do we change people's attitudes, and how do we support those who already have made that change into hopeful action.
Okay, a question about nuclear energy. So can we manage the sort of environmental trade-offs of nuclear energy as a climate crisis intervention? Do you think it's a viable alternative to fossil fuels?
I have to say I'm not an expert in this. I would like to think it is. I know that we have a problem with what to do with the waste, and we have a problem with security, and the concern about these small nuclear power stations that might be at risk of terrorist attack. There's a worry about how we would make them secure. I'm afraid I don't know. I know that countries like France have built their energy independence on nuclear, and that Britain has that in its plans. So I think it has to be part of a plan for the next 20 years.
I mean, what if it comes down to the last resort and other things have failed? Is that a fallback option?
Well, I mean, I think if we had moved sooner, we could be using other types of sustainable energy. But we are where we are, and therefore we have a kind of gap, don't we, that we've got to fill if we're not going to turn to fossil fuels. So I think nuclear is something we're going to have to live with probably for the next phase while we achieve this transition.
So I'm going to butt in here because I didn't scan my card, so I haven't been able to put my question in the Slido, and I know I still have others. So we do research in Usher also on the commercial determinants of health, and I mean my personal view is we've singularly failed to address the commercial determinants of health. We've failed to adequately address the activities of the tobacco industry, alcohol producers, unhealthy food and drink, gambling companies now are a particular problem. So how can we have any confidence that this is a commercial determinant of health? It's caused by human activity, but it's caused by corporate giants and the products they produce and the tools they use to attract us to use those products. So how can we engage with that from this lens when we really haven't done enough of it on the other topics?
I absolutely agree with you, Linda. This is a commercial determinant of health, and we have industries that are making enormous profits and that are unwilling to change, and they don't seem to see the need to change. So, as with the other things, with alcohol and food and sugar and tobacco, we have a real problem. Not only because these are health-harming products, but because the industries themselves have engaged in misinformation over a long period of time. We know that about the fossil fuel industry as well, and they're extremely good at it. And medical journals have, unwittingly sometimes been the vehicle for that misinformation as well. So I think it is an enormous problem, and my only solution, if you like, is that we have to put pressure on governments because nothing changes without legislation. So attempts to do voluntary action from the food industry, from the alcohol industry, from the tobacco industry have failed. Legislation succeeds. Chris Whitty has said, quoted by Richard Smith in an article in the BMJ, that politicians follow the public and not the other way around. So it is the public, we must make our voices heard to government, to create legislation, to put industry on notice that it has to change its ways, because I don't see any other route. I don't know if you have a different view.
Thanks. A tricky question on sort of inequalities and social justice. And again, lots of people across the Usher are interested in examining the impact of public health or other interventions on perhaps perpetuating inequalities, and sometimes underpinned by racism and colonial legacies. Are we walking into a trap with some of these interventions that you propose? Do we risk perpetuating those kinds of inequalities, and are we expecting people at the lower end of the socioeconomic spectrum to do more than those at the other end?
Well, we know that poorer people globally and poorer people within every country are suffering the consequences of climate change and other the commercial determinants of health much greater than those who are wealthier. We know that unless we are very careful, a transition from fossil fuels to a non-carbon economy will also impact the more vulnerable. And those of us from the rich world and those of us from the richer parts of society are going to need to take on more of the responsibility for that change as a result. I don't know if you remember, I showed you very quickly that slide which shows that most of the emissions come from 3 major emitters, so China, America and the European Union. That's pretty much half of the emissions that are currently coming out of the world. You know, we, the rich world, have got to make a much bigger shift because we bear a historical responsibility for the current state of affairs. So, I mean, I would agree with you. There's an awful lot of injustice already baked in, and we have to make sure that the transition, as far as possible, doesn't increase that injustice, and if possible, addresses it.
Can we move to something a little bit more specific? The use of plastics in medicine. So the slide that showed the impact of health services around the world was quite startling. Certainly in general practice during the COVID pandemic, it just seemed environmentally catastrophic. You know, we were using gowns and gloves and masks and chucking them all away after each patient. It felt like environmental vandalism, but you know, probably necessary at the time. But how can we reduce our reliance on single-use plastics in medicine? Because in some ways, you know, we've progressed to that from sterilising, but we seem to be sort of caught in a bit of a trap with plastics.
Yeah, no, I absolutely agree. I haven't got a great deal of detailed information on this, but I do know that the Greener NHS team, Nick Watts et al., has this as one of the things that they're looking at. And also, interestingly, the Royal College of Nursing, because they deal with, you know, endless gloves and a vast amount of plastic, are doing some really fantastic work. The pharmaceutical industry is onto this as well, because it will save them cost if they can reduce the amount of packaging and unnecessary plastics involved. Anesthetics, I know, is an enormously, you know, plastic-intensive or you know, packaging-intensive specialty, and the Royal College of Anaesthetists has got a programme on this. So I think there are a lot of people trying to work on this, and I absolutely agree that health has to take its responsibility to remove single-use plastics as far as possible in everything that it does. But it has to be done in a way that doesn't put people's health at risk. So it is a very challenging issue. I don't know, there may be people in the audience who know more about that than me. I'm sure there are.
So I think most of the questions have been addressed, and we had an excellent range of questions from the audience. But I guess that we asked you before about behaviour, but I suppose the other thing really is around public messaging and how we shift the dial for governments to really, I mean, the list of things that you showed us that we could do ourselves from Leeds, was it? I mean, that's not the kind of messaging that I'm seeing from government, and those are simple steps that we could all take. We know that governments need to invest in greener energy and they need to subsidise insulating our homes and all that kind of thing. But I just wonder if there's another approach to how we communicate to the public that we could use.
Well, I thought it was very interesting during Liz Truss's very brief premiership that she thought it necessary to tell the King that he couldn't go to COP, was one thing, very much a directive, but wasn't willing to talk to the public about whether they might turn their thermostat down a little bit and save some energy in order to not only save themselves money, but also to you know, help with planetary health. It's a very odd position to have taken, and I'm glad she's not in number 10 anymore, but for that reason as much as anything. I think we absolutely do need to be telling people, advising them on how to reduce their energy usage. We need to help them with home insulation. We need to help them with grants for heat pumps. We need to help them making it much easier to abandon their cars. All of these things that government can do. And it's very notable that in the European Union, and I'm pretty sure in Scotland, that is what has been happening. Governments have been helping people to understand what they can do to reduce energy use. And, you know, with the war in Ukraine is another reason for doing that. So I think it's a very odd position for government to take, that they're not even going to go there. And I hope it doesn't come up again. I hope that was an anomaly. And
can we finish, Fiona, with a further question about government and the fact that you were at COP0? That was that caught someone's attention, but the fact that the governments typically overpromise and typically make promises where the delivery will happen after the people in power, currently in power, are well and truly gone. How can we build in the sort of sustainability of the promises that are made? What are the mechanisms to make future governments accountable for what governments are saying at the moment at these COP summits?
Well, I mean, I think it is very distressing, and those of you who've been to COP, any of you who've been to COP, you know, it's an enormous kind of caravan and charabang of effort, and you know, and then actually what comes out is often so disappointing. And then when you look years later, the climate committee report for Scotland, for the UK, we're behind on a whole host of issues. So, you know, I think this is the political process that we have. It's far from ideal. I again get back to my view that public pressure within each country and at the international events to try to really give courage to the legislators and the politicians to meet the ambitions. One of the things, I don't know if I mentioned, was Ministries of the Future. As you know, Wales is the first nation to put a Ministry of the Future into law. And that's another thing, I think, you know, in terms of longer term accountability, that all countries could be doing. And you know, I don't know if Scotland's considering that. I think it would be a fantastic idea. But short-term politics is the thing we have to live with, and we need to keep the pressure up on governments to do what they need to do.
Thank you, Fiona. And can I please ask everyone to just show their appreciation? It was a masterful presentation. And Linda and I would like to now invite Sarah Cunningham-Burley, our Dean of Molecular, Genetic and Population Health Sciences, to propose a formal vote of thanks. So thanks very much, Sarah.
So thanks very much. So this is a real privilege for me to thank Fiona for such an amazing and inspirational talk. It's a real privilege because especially actually I haven't had any role in putting the event on, so thanks to everybody who have done that. And I know Aziz will go on to thank everyone in more detail. But Fiona, your talk was so open, reflective and frank. And I think starting with that personal story, which is actually a story of courage, but how we all should overcome backlash, which we experience actually in many aspects of our work, but particularly if we are going to move into tackling the climate crisis. And that requirement to maintain that steady steelness and boldness and commitment, I think, is something that we should all take away from the afternoon. So I'm sure that none of us were in any doubt about the urgency of the climate crisis, but you've been able to powerfully synthesize the evidence that I think we'll all go away with a sense of the urgency of the need to act. And you have empowered us to do that because you've provided, in a sense, a pathway of the different levels at which we are able to act. You use the term active hope, which is what I was also thinking in my head as you talked, because we can all kind of hope, but that could very quickly tip into some kind of passive fatalism. Well, we just kind of hope it'll all work out all right, but we don't need that type of hope. We need a hope that inspires action. We can create a livable future, as you've said.
the opportunity to do that is still in our hands, but it sounds like it's only going to be in our hands for 9 years. Well, what can we do in the next 9 days to make sure that we can hold that for 9 years so that there is a livable future for ourselves and for future generations? I think the Usher Institute, since absolutely at the core of who we are and what we want to do is the public's health and therefore the planet's health, we are in an ideal position to act, and to act at all the different levels that Fiona has suggested for us. Our research is impactful. We have all the multidisciplinary skills to use evidence to research impacts and to use that to influence and promote change. We've already had examples of the ways in which our teaching is embracing aspects of this agenda. Those of us that work with our students, most of us in the room, in one way or another will be doing that, can increase the awareness raising around sustainability and climate change across the curriculum. And students are our absolute allies here. It is their future, and their short-term future is also in our hands. So I think that kind of making friends is something that we can do across the generations as well as across the disciplines. And as an institution, the university is doing an enormous amount in this area, world-class research, and also its own commitments to net zero and to mitigating the climate crisis. So I suggest we all reach out to our colleagues across the university as well in order to increase our research commitments, our teaching commitments, but also to learn what it is we can do individually and collectively to make a difference, which we are urgently required to do. So Fiona, thank you so much, I think, for inspiring that action. I hope all of us will go away and work together to think, well, what can we pledge to do as an institute and mainstream this in everything that we do. And that can be individual things that we might think don't make a difference, but in the end, that collection of individual things alongside our ability to influence large-scale change through the importance of our research and education will help, hopefully, create that livable future that is dangling precariously in front of us. So Fiona, thank you very much for coming to speak with us today and for providing such a provocative but really timely message of what we can do. Have a very small token of appreciation for you in a paper bag and hopefully well procured in terms of its carbon footprint. So I'll come down and give it to you.
So we're coming towards the end, and just a few final thanks from me. So first of all, going to just also echo Sarah's comments. Fiona, that was wonderful. I think so much for us to take away and think about at individual levels, but I think also across the Institute, and I think we'll certainly be taking some of the lessons that you've kind of imparted very seriously across the Institute. Fiona, I also wanted to thank you for staying on tomorrow morning. You're going to be meeting some of our PhD students, early career researchers, and if any of you guys haven't signed up, then please do get in touch with the comms team. But thanks very much indeed for agreeing to do that. It's very kind of you. I'd like to thank Linda and David, been fantastic chairs for convening our, the event really. Also for, all the presenters that we've had. So we've had Sarah, Christine, Bruce, Hilary, Tim, Helen, Nina. I think it's no easy task trying to present in Hillary's case, a decade of work in 3 minutes, but I think everybody's done exceptionally well in that respect, so thank you very much indeed. I think Liz gave us a fantastic introduction to Fiona and the importance of this work, so thank you to Liz. To Sarah for a very important vote of thanks there. Vision events have supported this, and Edinburgh First, and very grateful to them as well. Also, I'd like to thank everybody who's been at the marketplace, put up stalls, everybody who's presented their posters. A lot of work's gone into that, and I think it's been absolutely fantastic to see the work that's going on. Finally, the Usher Institute Communications team has coordinated the effort today, and an enormous thank you to them as well. So, if you could just join with me and just thank everybody involved putting today on. Thank you. So just looking forward, we've got a wonderful colleague, Susan Hopkins, who's going to be giving the Usher Institute lecture for next year. So that's a date for your diaries, please. Susan's been, obviously had a pivotal role in the pandemic and with the UK Health Security Agency, so really looking forward to that. And then in subsequent years, for those of you who've been out to Bywater recently, the new building's coming on absolutely fantastically. We've designed this really to try and promote team working, being health promoting, and reducing our carbon footprint, and it's very nearly done. And so future events will hopefully take place in that brilliant new building that's being put together. I think it's been a wonderful afternoon. Thank you to everybody who's joined us online. We hope really that you've been able to engage. We've tried to design the Q&A format so you had maximum opportunity to participate. A lot of thought went into that, so I hope that's worked out, but please do give us your feedback. For those of you in the room, you're very welcome to stay. We hope you will stay for our receptions downstairs, and also the opportunity again to meet with the PhD students and those in the market stall. Thank you, everybody. I've thoroughly enjoyed it, and thank you.